Okay, good afternoon once again. You're all welcome to today's CME. And I can see our speaker has already started sharing his slides. He is Professor Anthony Ali Mshelia, a chief consultant psychiatrist with the Federal Neuropsychiatry Hospital, Maiduguri. So it's an honor to have you in the midst of us, sir. And we believe that this time that we're going to spend with you will be quite educative to all of us. Therefore, I will call on everyone to mute their speaker and listen attentively. And if there are questions or any points of clarification, you can, jot it down. And after the presentation, I will open the floor for questions and comments. So you're welcome once again. So our presenter, sir, you can go on with the presentation while others join us. Thank you.
All right. Thank you very much, and good afternoon to every one of you, our elders and colleagues. You are welcome to the second day, and my details are already shared there, and I'll be talking about identifying common mental illness in medical practice today. That's what we'll be discussing. What are our learning objectives? We need to understand common mental disorders seen in medical practice to be able to recognize and diagnostic approaches to mental illnesses seen in practice, learn red flags and when to refer, review the management basics and referral pathways for mental illness, especially in medical practice, appreciate the scale of the problem in Nigeria and low and middle income countries also where we belong. So why is it that this identification, this topic matters? There are reasons. Mental disorders are common and often co-occur with physical illness, so that's why we need to identify them, or else we might miss them. WHO reports nearly 1 in every 7 people in the world live with a mental disorder. So you can see that the statistics is really big. Mental disorders can severely disrupt daily life and cause long-term suffering if left untreated with far-reaching consequences. So we don't want it to be left untreated so that the consequences which are far-reaching that affect the individual will not go. So that's why we are looking at this topic. Early identification also improves outcome and reduces disability. Primary health care or primary care is the key to closing this treatment gap. So these are the issues that why we have to look at this topic and be able to discuss it at length. So by introduction, when we talk about identifying common mental illnesses in medical practice, it involves recognizing the ability to recognize changes in emotions, in thoughts, and behaviors, such as persistent sadness that is observed in individuals or clients, excessive worry about minor issues, withdrawal from different activities, family or social activities, sleep or appetite changes in those individuals, and difficulty functioning in daily life. So when we observe this, then we need to look at beyond only the physical problem to look at it that there's likely a comorbid or it's likely only a mental illness. As a doctor, we need to use combination of patient history, physical examination to rule out medical causes, psychological evaluations and questionnaires to assess symptoms and make diagnosis. So in our examination of every patient that comes, we must look at it on both physical and psychological aspect to evaluate. Common disorders that we find include depressive disorders, which can coexist with so many other physical illness, anxiety disorders, alcohol-related disorders, somatoform disorders, which often present with overlapping symptoms like unexplained body pain. So when they come with pain, it might just be a somatoform disorder or any other problem that is mental, which is not physical. When we talk about mental health, it's a disorder which is known, is either called mental illness or psychiatric disorder, or a condition that affects the way that individual behave. So the basic things about mental disorder, it affects the way the person thinks, the way the person behaves. It also influences emotions and how one regulates those emotions to know when to react or when not to react. A person may feel anxious or empty, have racing thoughts, or have trouble eating or sleeping. There are several different types of mental illnesses. They may impact your ability or my ability to function at home, at work, and school. So usually you find that this thinking, this behavior, these emotions, this ability to regulate your emotions will affect the individual either at home, in school, or work. Once you see that, then you begin to have a high index of suspicion of mental disorder. Mental disorders are common. About 1 in every 8 people around the world live with one form of disorder or the other. Some can be so subtle so that the individual can function normally, while others might be glaring that it will incapacitate the individual. What are the risk factors and protective factors for mental illness? The risk factors and protective factors may influence this health and also operate at multiple levels. So some of them can be at risk, some can be protective. We look at the individual factors, such as emotional skills, substance use, and genetics may increase the vulnerability to mental health problems. Social and environmental factors, they include poverty. Studies has been done severally. One of the key social factor for as a risk factor for mental illness is poverty. Violence, inequality, and environmental deprivation also increase the risk of experiencing mental health condition. In case of environmental deprivation, when we have all these disasters and so on coming, there are a lot of things that happen so that the life of the individual goes towards a downward trend, and it affects the mental health of that individual and the conditions of his psychological well-being. What other risk? Risk can emerge at any stage of life, but those occurring during sensitive developmental period, especially early childhood, are particularly much more harmful. For example, the issues of harsh parenting. Physical punishment can damage the child's health, and bullying in school is a leading risk factor for a lot of mental conditions. Many might not be seen at that developmental stage of the child, but will manifest when the child begins to enter the adulthood. The impact of those developmental trauma which the individual has passed can lead to a lot of mental illness. Protective factors similarly occur throughout our lives and helps us build resilience. Uh, Sometimes I was speaking about resilience, the ability to be able to stand up when you go down, when there are challenges. They include individual social and emotional support. Those things help to build resilience and are protective. Your social network, your emotional skills, positive social interaction, access to quality education, work that is decent and satisfying to the individual, safe neighborhoods, and strong community ties. Once those things are there, they tend to be more protective. When you know that this neighborhood is safe, there are no problems of substance, drug abuse, or armed robbery, there are not problems of stealing. The community ties that individuals have, these serve as protective factors to mental health. Mental health also risks and protective factors can be found at different scales. Can be local challenges affecting individuals, families, and communities, while global threats such as economic downturn, as we have experienced in the past, disease outbreaks. Remember the COVID situation, the rate of mental illness increased with that outbreak of those diseases. Humanitarian emergencies where there are disasters, there are flood, there are hurricanes, there are drought. Forced displacement like we have experienced, especially in the Northeast, issues of the insurgency, and climate change, where you have weathers now that fluctuate at a much more rapid way than it used to be. All these things can impact the entire population depending on where they are affected. Commonly here, we tend to experience issues of drought and floods. But when you go into the West, you find that they experience a lot of things that are mostly hurricanes and other form of disaster, earthquakes when you go to somewhere like Japan and the like. No single factor can reliably predict mental health outcomes. Many people exposed to risk factors never develop a mental health condition, while others may be affected without any known risk. However, there's an interplay of these determinants. Collectively, they tend to shape the mental health of the individual. So it's a collective balance of whether you are exposed or not exposed, depending, like I have mentioned earlier, the issues of the upbringing play a very good role in issues of mental health. So what is the global burden of mental disorders? If you look at this figure, this is taken from WHO. About 970 million people had a mental disorder in 2019. And the topmost is anxiety and depression are the most common. And if you look at it, is the large increase of mental illness after COVID-19, the estimate shows, especially this was done taken in 2020, you can see depression, anxiety has about 60%, while other mental disorders just occupy 40%. So you can see the great burden on mental disorder, especially depression globally. What is the distribution of mental disorder by income? Majority of people with mental disorder lives in the low and middle income countries, which Nigeria belongs. That is why earlier I mentioned, I say one of the things is that poverty, because poverty brings a lot of ripple reaction. You are not able to cater for yourself, you are not able to feed well, certain nutrients are not there, the challenges of life stressed up the individual. Health system gaps and workforce shortages are also available in low and middle income countries, and this increases disability because the ones that need the care are not able to reach because of the gaps. As you look at Nigeria, you find that most of the health personnel are dwelled or settled in the cities, and the majority of the population are in the local areas, and those people cannot get the health system that they desire. So it creates a gap because of the workforce shortages, especially with recently that this issue of JAPA is increasing in this country. So it increases the health system gap and disability. So the income of that country also tends to affect it. Common disorders that we see in general medical practice. If you look at the study, we showed the pie chart, you can see depression, anxiety has about 60, while others about 40. You can see that's no wonder depression tends to top common that you see coexisting in general medical practice. Anxiety disorders, which can include generalized anxiety disorder, panic disorder, agoraphobia. There's also issue of substance use disorders. Most of us here, especially in the Northeast, you notice that this is a very common thing and it's a prevalent thing. All kind of substance. Daily, they are creating what we call novel psychoactive substances, new ones that you don't know. As the NDLA and certain things are blocking certain substances, they are creating new ones. Somatic symptoms, somatoform disorders, these are generally seen commonly in outpatient clinic in GOPDs. Sleep disorders, psychotic disorder like schizophrenia, though it's less common, but it has a high priority because it is highly debilitating in that individual. Neurodevelopmental disorders, which are seen in children, are also common that we see. Attention deficit hyperactivity disorder, autism, and the likes can also be seen. How do you recognize warning signs in individuals for mental health disorders? We need to look out for patterns of changes, not isolated incidents. What do I mean? A pattern of change, like for sleep, there's a generally decreased hours of sleep or decreased refreshment after sleep and certain things. A pattern that has been ongoing for quite some time. You can notice, for example, in depression, mood changes, persistent feelings of sadness. It is normal for an individual to feel sad once in a while after a bad news or something happened. But when it persists beyond the normal, and the normal is that we expect individual within hours to a few days will get out of that sadness. But when it persists for more than 2 weeks, that persistent feeling of sadness, then it begins to bring a red flag that there's something going on. Feelings of hopelessness, irritability, or extreme mood swing. Today, the person is excited, very happy, at top of his spirit. The next moment, the person is very low, depressing, and can even be crying. When you notice those fluctuations, then it begins to say that it's a warning sign something is going on psychologically. What are the behavioral changes also? Social withdrawal. Somebody who is outgoing begins to now withdraw from friends or activities that will be with his friends. And then changes in eating or sleeping habits. Eats more or sleeps or eat less, sleeps more or sleep less. Increased substance use too. Maybe the person usually just takes a weekend bottle of 2 or 3 drinks, but it becomes a consistent on a daily basis that he takes the alcohol, then there is a problem. And then also difficulty with personal care. You observe changes in the hygiene of the individual, either is not kept or his clothes are dirty or wrinkled or whatever it is. Then it begins to say that there's something going on that is psychological. What are the other warning signs? Cognitive changes, confused thinking, poor concentration, memory problems, difficulty with logical thought. Somebody who could argue and discuss politically or academically suddenly is finding it difficult to discuss. When the person begins to forget minor things, then there are problems that are going on that are brewing. Functional impairment, unusual drop in functioning at work, either in school, in performance, academic, or at home, such as failing at familiar tasks or quitting activities. Somebody who you know will take the bull by the horn and fight everything suddenly is quitting or giving up at a stage that is not supposed to, then we begin to know that there are warning signs. Physical symptoms, unexplained headaches, always complaining, stomach aches, or other bodily pains that can be related to increased muscle tension or stress. When the person is stressed, those things can come. So we need to look out for that. Other things is that the person feels detached, feeling of being disconnected from oneself or reality, experiencing paranoia. He feels every other person are talking about him, are planning evil or wickedness towards him. He might be hearing voices or so, feeling or smelling or seeing things that aren't there, having some form of hallucinatory experiences. Thought of harm. Any mention of self-harm or suicide ideas or thoughts requires immediate professional attention. It is an emergency. Maybe I just mentioned it here. One of the things is that WHO made a report concerning suicide. Every 40 seconds, one person takes his life. It tells you the gravity and the importance of that thought. Once it comes, you have to arrest it. One person kills himself in the world every 40 seconds. So you imagine by the time this presentation is through, how many people have died by suicide. So any mention of self-harm or suicide ideas should be taken with as a case of urgency. Immediate and professional attention is needed. So we move on to what are the things that you might see in children. There are changes in their appetite, in adults, sex drive and daily functioning that cannot be explained by medical condition, difficulty identifying reality, excessive worry, fear, or having unusual thoughts, feeling disconnected from himself or from others, heightened sensitivity to light. Some will not like too much bright light or sound or smell. Loss of interest in usual activities. The thing that used to excite the person, suddenly he loses that. The mood swings or exaggerated emotions. Usually you find some individual things that naturally will not trigger anger. The anger will be so exaggerated beyond that provoking factor. Performance issues at work or school or relationship challenges, self-harm or thoughts of suicide, trouble sleeping at night. So when we see these are red flags or information that something is brewing in this individual. What of in children? We see them having difficulty sitting still or paying attention, which usually not only in the home but also in the school and other places. There is excessive worry or fear, like not wanting to go to bed, especially when they experience nightmares. Then we need to critically look in what is going on. Significant changes in their mood, sadness or withdrawal, decreased interest in their favorite activities, frequent tantrums, defiance or aggressive behavior, problems at school, home or with friends, could be avoiding friends and family. Also academic decline in school. You notice in those individuals, then you need to find out what is going on. Probably there's a bullying that is affecting the child. Changes in sleep and appetite patterns of those individuals. A child that used to eat well suddenly eats only a little and tells you he's satisfied. Then there needs to be investigated whether there's a problem or challenge, which can be psychological here in this nature. So when we look at mental disorders, what are the causes? I broadly divide them into two. I call them nature and nurture. Nature has to do with our genetics, the genes we inherit. This may increase the risk of certain mental health conditions. However, having this gene does not guarantee one will develop the disorder. So it's an interplay of nature and nurture. They all pose a risk for an individual. The other aspect of the nature is brain chemistry and function. Our brain uses chemicals, we call them neurotransmitters like dopamine, serotonin, norepinephrine, and the like, to help control our mood and behavior. Disruptions in the balance of the dopamine, norepinephrine, serotonin, and so on, these functions, when there is disruption in some of these chemicals, they may lead to a lot of mental disorders. For example, I give you the example of especially dopamine, which is a major implicator in schizophrenia. Hyperdominagia is one of the cause of schizophrenia. That's why we give drugs that try to reduce the dopamine level and also the sensitivity. So once there's a disbalance in that individual, so that nature is a risk factor, but it doesn't guarantee that all will develop. Then the other one is nurture. Nurturing is the life experience or the environmental manipulation or influence. Stressful experiences, especially in early life, in childhood. I mentioned earlier how the person developed the environment, the caring, how the parents handle the child, and the things that were in the environment of that particular may increase the risk of that child having a mental disorder. Factors like substance use. Children who grow up in an environment where there's high level of substance use, through experimentation can go into substance use. Where substance are also availability of those substance can also lead to them to be able to try them. Also, what are the social support and chronic medical conditions may play a role. The good social support, that's why they need. You find that not to be in a way, but children that grow up in broken home are also high risk of mental disorder. That's why parents need to watch that before you take that kind of decision. Looking at the etiology, common mental health disorders is multifactorial. We have mentioned it involves psychological, social, and biological factors. The biological are the nature, the social are the environment, psychological to environment depending on the interaction of the individual. Many of common disorders have similar etiologies. So it's difficult to find that just one just based on classical only biological. It's an interplay of biological, social, and psychological factors that bring forth mental illness in individual. We take a look at some of the major common disorders, depression. What are the key points that we discover that we're able to feel that this person is likely having depression? One, affecting feelings of sadness and disrupting ability to function. So when you have sadness, which is extreme, and that's what we call depressed mood, usually in depressed individuals, it tends to occur for a period not less than 2 weeks that has been persistent. Like I told you, sad news can come, but usually within hours and days, we are able to get out of that. But when the sadness is so deep and persistent, then it becomes a symptom for depression. Persistent low mood, anhedonia, sleep or appetite changes, fatigue in those individuals when they begin to lose interest in certain things. They can present with somatic complaints also in medical settings when they come complaining of pain here for this and that, multiple somatic pains. We need to always, when we see a patient with depression, it's very important to ask about suicidal thoughts. Always ask, have you felt like ending it? Have you felt that life is not worth living? Because that could be a key to saving the life of that individual. In the clinic, we can use the primary health questionnaire 9, patient health questionnaire, PHQ, can be used to screen if in doubt for that illness. Then anxiety disorders, these are some of clinical cues that we see. It's characterized by excessive worry, fear, and avoidance behavior. Restlessness and autonomic symptoms can also be present. Either the BP is high, the heart rate might be increased, and so many other things. Panic attacks, sudden intense fear with palpitations, feelings of breathlessness as if the person is going to choke or there's no breath. Could be have sweaty palms, trembling, having trouble sleeping also at night, having trouble controlling their worries. They begin to ruminate over and over the worries. Often tends to occur comorbidly with depression. The other common one is substance use in medical practice. We have the issues which is prevalent. Alcohol globally tends to be top. Then we have the opiates, which can be natural, occurring, or synthetic. Commonly here you see individuals that abuse tramadol, especially those that are engaged in high labor, high energy labor, laborers, people that are tailors trying to meet up the needs of the festivities for sowing, they take all the farmers and so on. Then we have cannabis also, the stimulants commonly encountered. These are the ones that they take commonly. While you see person with substance, we need to look for withdrawal symptoms. usually tends to occur when the individual is trying to stop the substance. And those withdrawal symptoms can be, for example, in the case of codeine, now one of the withdrawal symptoms, because codeine naturally tends to cause constipation. So when they withdraw, they begin to have diarrheal symptom, which if you do a stool microscopic culture, you will not find there's no any infective organism. It's just because of the withdrawal symptom. So when we see, let's not be quick to start giving antibiotics or whatever it is. We need to look at it. Risky behavior also is a common thing. The person is reckless in every activity that he does. You find that these days when you go to Abuja, most Fridays and Sundays, there's a lot of risky behavioral accident following taking substance, being having night out. Then we need to look at for also medication interactions. Many of them take more than one substance. So it could be that they are taking multiple substances, and the manifestation of the interactions that we are seeing, somatic symptom and related disorders, multiple unexplained physical symptoms, we need to look at it. Maybe the person is having a somatoform disorder. Rule out medical causes, screen for illness, anxiety, which is what we used to call hypochondriasis before. It is now called illness anxiety disorder. And then for also functional disorders in the individual, could be schizophrenia, it could be bipolar, it could be whatever other disorder. Psychosis, what are the red flags in general practice? When you have a new onset hallucination and delusion. Let me say here, there are hallucinations that are accepted as normal, which is what we call the hypnagogic and the hypnopompic hallucination. The hypnagogic hallucinations tend to occur when the person is about to sleep. Between wakefulness and sleep, they tend to experience, which can be normal, so that we don't always tag all hallucinations. So then we have hypnopompic, where between wakefulness and sleep, they tend to occur. It can occur in normal individuals. Then the others is that new onset delusions, where the person begins to feel certain people are against him or want to harm him or planning evil towards him. Disorganized thoughts, such that when the person speaks, you cannot really make out meaning out of his statement or word. The speech is also disorganized, his behavior is also disorganized. Changes in mood and emotions of those individuals. Acute agitation or safety risk, then we need to look at those as red flags, and it needs urgent referral to see a psychiatrist. What are the suicide risk assessment? Directly asked about suicide. We suspect, any individual we suspect, we must ask of that. Ask the individual, do you feel like life is not worth living, or you feel like ending it, or are there thoughts that you feel like taking your life? Then you will need to ask about the intent. Has he made any intention to do that? Are there plans on ground? Because most people that commit suicide will not give you detailed information. You have to be able to pry, to press them to be able to give you information. Also look out for feelings of guilt, hopelessness, worthlessness in those individuals. Once they begin to experience those ones, then it's directing them towards that. Likely there's depression and going towards suicide ideas. Identify protective and risk factors. We've mentioned about those ones, and then earlier, look out for safety planning. The ones that want to commit suicide will plan it in such a way that people will not be able to know. But the ones that are just seeking for attention, which is what we call deliberate self-harm, those ones were attention-seeking behavior. They will cut themselves and shout or scream or put themselves in a way that can be found. But the ones that want to plan suicide, we must look at for all the plans that the individual are planning to take their life. What are the physical causes to consider when we are looking at mental illnesses? Individual with thyroid disease, because it can look like a bipolar because of the increased energy activity that the individual might have, decreased need of sleep. Anemia too will look like a person who is depressed. So we need to also be that. Individuals with B12 deficiency, infections, metabolic abnormalities, hypokalemia, hyponatremia, these are things we need to look at when we see people that are coming with thinking that it's psychiatry. We must cross-check and see. Always screen for reversible medical causes first. Once you can get, you treat. But once you are not sure, then you need to refer to the psychiatrist. Medication side effects, beta blockers are common. They can give individual to present with depressive-like symptoms. Steroids, interferons, some antiretrovirals can do, like ephedrins can cause mood symptoms. Levetiracetam and pregabalin can cause mood changes and psychotic symptoms. I've seen a few cases here where a patient was on levetiracetam and had a psychotic breakdown, even a pregabalin. When the drugs were drawn, the individual returned to normal. So when we have SOD, let's look at those medication side effects than just looking at it as a pure psychiatric, but we need to be careful. So some medications can cause. Always review medication list carefully of individual to see what is it that is taken. Like for the patient I had with pregabalin, the patient actually knew. She was placed on the medication, and once they used to give her, she stopped taking it. But the relative insisted after the prescription, they went and bought another brand because if they bring a particular brand, she knows it's pregabalin, she will not take. When they gave her the new brand, the symptoms came, and that was how we were able to identify that it caused that psychotic breakdown. So let's watch out for medication side effects also in practice. How do we assess when we are for mental illness in normal patients that we see? Let's scrutinize the presenting complaint and history of that. Look at for past psychiatric history because many of times we miss this out. And the past psychiatric history in this aspect, not only have you seen a psychiatrist, have you seen a traditional healer also for any form of mental illness, which can be in the past? Have you sought prayer houses? Have you seen a malam for Tofi or something? They said you had mental anchemaka aljanu or something. Sorry, I have to bring in Hausa so that we can understand the concept. Past medical history and family history also. Because like we mentioned is when you look at mental illness, it has to do with nature and nurture. So you ask for family history. Is there anybody in your family that has a mental illness?
Sorry, am I the one not hearing the presentation again? The audio has gone off.
Hello, sorry, there is a little technical glitch. Just give us a few minutes, we are going to fix that up. And the presenter will come back online soonest. Thank you.
We need to also, we also have to look at differential diagnosis. When we are considering depression, do we have to find out about issues of recent bereavement or there has been an adjustment disorder in that individual? Probably something had to happen that changed job or family or something. Panic disorders also versus cardiac arrhythmias. We need to look at it when we have panic disorders. Organic versus primary psychiatric disorder also need to be considered as a differential diagnosis. What are the red flags and urgent referral when it needs? When there's active suicidal ideation with a plan, or we have an individual with severe neglect or what we call catatonia, taking odd postures, which a normal individual will not be able to standing for longer durations than necessary. Or we have severe psychosis in those individuals, probably hearing voices and acting out on those voices, or acute functional state or delirium in those individuals. It begins to tell us a red flag. Let's need to look for a psychiatrist to refer to be able to manage such situation. What are the management framework in the primary health care? Counseling. Some of the psychiatric problems that might come even in the primary care just need to listen to the individual, active listening and counsel, and give solution. Some might not need medication. It could be just psychoeducation or brief form of psychotherapy intervention, psychosocial intervention. Probably the individual is just having a marital problem, which just a minor family therapy, bringing the husband and wife to sort out that problem. It could be a counseling, probably a wrong decision. However, you can start antidepressant from moderate to severe, but once it's mild, basically it will just involve counseling, psychoeducation, or some form of brief psychological intervention. The issues can be resolved. When it begins to get moderate, severe, then medications can start. Monitor response and side effects. Refer if there is no improvement. Most medication, if not almost all drugs, have side effects, so we need to be aware of the side effects and monitor them. Commonly, like the amitriptyline that we tend to prescribe for depression, one of the things is that in the first few days, it causes dry mouth of that individual. So once after that, it is transient, it goes off. So we need to do that. What are the psychological interventions we can do? Brief cognitive behavioral therapy, informed techniques. You try to look at the problem and see how you can solve. So it's more of a problem-solving therapy. You can also do interpersonal, if it has to do with another person, the relationship and so on, to look at it. Be able to pick out the wrongs in the individual and in a polite way put that once you adjust this and that, it will be able to help. We can use task sharing with trained non-specialists where available. Psychologists, social workers might be able to also use that to share tasks. What are the pharmacologic basics that first-line treatment, especially when we have depression, is selective serotonin reuptake inhibitors, also used for anxiety, but we need to monitor for drug-drug interactions. Let's start low, titrate slowly, counsel about side effects, and then adherence. Note, know when to refer. Once treatment-resistant cases or severe psychosis, bipolar, complex comorbidities, high suicide risk, or diagnostic uncertainty, then better to refer. However, in referral, inform the person you are referring what I have done, the steps I have taken before referral. We've seen cases where referral are made and no documentation, nothing was done. Only the patients will give you information. So let us have that. In practicing, especially identifying mental illness, we need to also look at cultural consideration in low and middle income countries. People don't want to come, so you find that people that have a mental illness will prefer to see the GP. Why? Stigma. So it is left for the GP or whoever is seeing the person first to be able to douse that issue of stigma. Many have spiritual beliefs. They believe that all those things is an evil spirit or something that is going on. Traditional healers influence health-seeking behavior. If you look at the general pathway to care, especially here in Africa, most people that have problems tend to look for traditional healers or spiritual first. Everything is over-spiritualized. It is after they have done and cannot that they begin to come to the physician. Adapt screening and interventions to local context. So try to understand the culture of the environment and the place you are staying, because that culture will help you in their belief and culture and their health-seeking behavior, how they will communicate and present. If you don't understand that, then you have problems. One thing I've observed, especially in this place here locally, everybody attributes any form of mental illness to a spiritual attack or a form of spiritual problem first, before they now begin to seek for medical help. So look at this graph. You can see a large population of the low and middle income countries do not receive the needed care. There is a gap, almost 82%, while in the high income, the gap is just 18%. So you can see the need why we need to people to be aware of identifying mental illness so that that gap can be reduced. If you leave it to only psychiatrists, then it will not be able to be fulfilled. So that's why we are having this, so that we can identify to reduce that gap compared to the high income countries. Look at Nigeria as a snapshot. Just look at the number of psychiatrists. We have about 0.1 per 100,000, while in the global median is about 1.4 per 100,000. So you can see, that means if you are looking at this figure, if you extrapolate now, you have like one psychiatrist to about 1 million Nigerians. And that is grossly inadequate. If you look at it in the Northeast itself, it is less. Because in the whole Northeast, maximum probably 24, 25 psychiatrists only in the whole 6 states, with Maiduguri taking a lion's share of about 18 to 20. The other states have 1 or 2 and so on. So you can see that looking at Nigeria, there is a gap, and therefore there is a need to bridge that gap by having individuals that are non-psychiatrists to be able to understand in medical practice, to understand those basic things and be able to manage them and be able to refer when necessary. When you look at it, compare high income and low income, you can see the workforce of mental health workers per 100,000 global meridian versus Nigeria and low middle income countries. You can see the high income about percentage untreated 40%, while we have 80% untreated in the low and middle income countries. So there is a huge gap. See the gap comparison also when you look at mental health spending per US dollar. This is WHO study. You can see the low income, which Nigeria belongs, is almost not possible, is almost absent, because it's about 0.5%. That's why it's not existent. But you can see in US dollar per person in individuals in high income countries. So there's a huge gap. Generally, not even only mental health, but health is actually underfunded in most low and middle income countries. So it creates a gap in the healthcare system. What are the common pitfalls in identification? We most of the times, individual attribute symptoms solely to physical illness. So when somebody comes with a physical, let our eyes be open, not only for physical, are there a possibility that there is a comorbidity, so that we don't fall into this common pit? Many a times we overlook substance misuse or medication side effects. We don't ask about suicidal thoughts. Some will just leave the consulting room and then the person goes and commits suicide. Why? We didn't ask about suicide. So once you see any of the red flags, let's ask about those information so that we don't fall into these pits. Communication tips. In communicating to your patient, we need to use empathic words. We need to be non-apostolic, non-judgmental. What do I mean by that? Let's not for example, somebody who is taking a substance, don't go and use a religious background that whether the Quran or the Bible says don't take this. No, it is also as a sickness. So look at it as the person is sick and be able to help him, not from the point of being apostolic or non-judgmental. If you want to stop it, you can stop it. Are you not the one who know? Let's be empathic to the individual. Common tip is when you are empathic and non-apostolic or non-judgmental, many of them will give you the information. But when you are not, they begin to shut down that information. Normalize the assessment and explain why the screening matters for such individuals. You have to also do a brief interview, opening, asking about mood sleep. When we don't ask those questions, we don't get them. Ask the individual whether there are thoughts of self-harm or there are things that's going on. Transition to assessment and then safety planning. So we must be able to look at all those things in a balanced way. The questions we ask, the things we ask will give us the information that our clients, when they come, they'll be able to do. So what is the summary and the takeaway of this presentation? Common mental disorders are frequent in medical practice. We need to know that. So whatever we are practicing, whether a surgeon or a physician, know that they can co or and they are common. Use brief screening and safety checks to ask by asking those simple questions. Are there any problems? Are you having problems with your mood, with your sleep or appetite? Or do you feel any change in your behavior or so? Have some people complained about certain things about you? Those small questions can be a lifeline to saving that individual from going into disability because of that mental illness was not identified. Let's integrate care, task share, and refer when necessary. What do I mean? You have to integrate to work. Look at the patient holistically. And when you are done to your own limit, you should share tasks and be able to refer when necessary. Thank you for listening.
Oh, thank you very much, Prof, for this very, very exhaustive session with you, identifying common mental illnesses in medical practice. And, doctors, in one way or the other, whether in the hospital or within the community, we get to, meet people that have mental disorders, people that need mental, the assessment and management. So this teaching wouldn't have come at a better time like this, because there are a lot of things that we ignore, and they are, killing a lot of people in the society. The rate of suicide is going up, even here in Taraba. I remember recently, I think about 2 or 3 months ago, someone committed suicide here in Taraba. So these are some of the things that we miss. Some of these patients usually come to us with different problems, but we miss some of these histories. And because of that, we find out that some of these patients that would have been saved by us will end up, dying. So mental illness is very common. And I think we'll leave the floor open. I believe this session has, gingered a lot of thought in us, and it has refreshed our mind. And I know many people have questions. But before then, let me entertain that of Dr. Teru. He said, thank you for this enlightening lecture on mental health. Then he went further to say, amitriptyline is commonly prescribed for many suspected mental illnesses by us. Is this appropriate, or a better option exists? So I think, Prof, I don't know if you got that question.
Okay, can I go ahead and respond?
You can go ahead, sir.
Yes, amitriptyline is commonly prescribed. It's a tricyclic antidepressant, and apart from that, it has multiple other functions. Commonly prescribed, especially we here, one, it is cheap. Two, a lot of the symptoms that come, especially with depression, tend to be individuals that have issues of insomnia, and amitriptyline has a very good sedative property. So it's common because it is given so that it helps to manage the depressive or anxiety, and then also helps them to improve on their sleep pattern. However, amitriptyline must be prescribed with caution. Why do I say so? Especially people that are hypertensive or in the elderly. Hypertensive, it can cause cardiac arrhythmias. It tends to affect the QRS complex in those individuals. So we need to do it with caution. So we must be able to check. In a developed country, you need to do an ECG to be able to, before you prescribe. So that's that. Secondly, one other side effect I mentioned earlier is dry mouth. Then two, it can also be used for individuals that are likely prone to suicide because of the cardiac arrhythmias that I mentioned. They will take the medications and take large doses, so they go into cardiac arrest and they can die. There are other uses apart from depression which is used for. It can be also used for individuals in having migraine, which can be used as a preventive medication to reduce the trigger and frequent migraine. Also, we use it commonly for individuals who have enuresis, that's bedwetting, but it go together not only as the medication, but also with some psychological management that we need to give to those individuals. So it's commonly prescribed, but you need to be cautious. That's why I mentioned in one of the slides, you start low and build slowly. For me, like a psychiatrist now, I can prescribe up to 200 milligram, but it comes in 25, there are some in 10. So I advise cautiously to do, you prescribe maybe 12.5, 25. By the time you reach 50, then you need to know that there is a problem to refer to a psychiatrist. Thank you.
Okay, thank you very much, Prof, for the detailed explanation concerning the use of amitriptyline. Of course, Prof says it's cheap, it has sedative effect, it improves sleep pattern, and is useful in migraine. So I think these are important points that some people, including myself, have picked. But then I would like to ask a little question too. We know substance abuse is something that is very common in our society now. A lot of people,
Yes.
take, some of these drugs to relax, while some take them just to feel high. So I would like to know, recently some politicians, they were advocating, legalizing some of these substances if being elected into office. So what is your opinion concerning this? If at all they get into office and they legalize this, what is the risk that it portends to mental health in Nigeria? And if there are measures that the government can put, or even at the moment, we know because of the increase in all these things, are there measures that the government has in place apart from the NDLE to control some of these things? And concerning those people that want to legalize, what is your opinion, sir?
Okay, thank you very much. My opinion is that I will not advise for those substances to be legalized, because the damage they do to our youth and to the society is enormous. So, because they have a lot of psychiatric problem, and worldwide, especially psychoactive substance, when you talk of issues of cannabis, cocaine, heroin, the opiates and the like, the rate at which to relapse, 80 to 90%, no matter whether you give them the best treatment, best center, tend to relapse. So getting out of it is a very terrible, is difficult, because there's no drug you can give to stop somebody from substance. Rather, you do what we call motivational interview, where you ask the individual and discuss, looking at merit and demerits or advantage and disadvantage, and see, to be able to make him to reason. The drug medication we give is just to stop the psychotic behavior that the individual does, so that to be able to flush out all those chemicals. But to tell him to stop, there's no drug. So I will strongly advise that it should not be legalized. The government can do well to be able to do that is that, for example, one of the major challenge we have here, I've seen in the north, especially with the issue of tramadol. I believe that there are alternatives of analgesic than tramadol. It is destroying our youth. Government can selectively discuss with people to know which drug to ban or what not to import into the country. I believe, like, if tramadol, for example, is stopped, we have alternatives. Then government can go ahead to stop that, and then it will reduce a lot of problems that we have when it comes with the issue of dependence, psychosis related with those substances. So the issue is that government can find a way of control, not only NDLE. And when I say government, we are also involved. We know in the community, those that are involved in that, the police too are actively involved. Who are those people that are planting those cannabis, those that are importing those drugs, substandard, putting it in different form? So there must be a holistic approach to see how this thing can be stopped or regulated. For example, I give you, in the Francophone country, I've gone around Africa, there are a lot of medications you don't get without prescription. So that could be another way to do, whereby pattern medicine stores or pharmacies are closely monitored that they cannot sell until with a prescription. So it reduces some of those substances, especially the illicit When I say licit, I mean the drugs that can be prescribed that are used as psychoactive substance. Those are the licit, while the illicit are the ones that are the hard drugs, so to say. So I think those are things I believe the government can do to be able to mitigate some of these challenges. Thank you.
All right, thank you very much, Prof, for the insight. And a question from one of us is, a patient whose main complaint is thinking too much, insomnia, and general body aches, seeking help for the first time. So he's asking if it is okay to give sleep pills like Lexotan before considering antidepressant.
Yes, if you don't find any cause that is causing that insomnia, yes, you can give, especially when you don't know identifiable cause that this is this. But usually, to give the benzodiazepines like the Lexotan you mentioned, we advise not to give probably maximum between 5 to 10 days. Initially you can give 3. It should not exceed 2 weeks, because after 2 weeks there's high risk of being dependent on it, so that the person now cannot sleep without those drugs. And usually when you look at it, you will discover that there's certain background, maybe a loss, a separation, something that has happened that caused the individual to be having insomnia. Apart from that, there are other non-medical treatment, what we call sleep hygiene. These are things that individuals need to find out from them. People that sleep, because in sleep cycle is a 24-hour thing. Somebody who sleeps a lot in the daytime for hours will not have enough sleep at night. So such individuals, you just advise them no sleeping in the daytime, only sleep at night. 2 is that issues of use of level of stimulant, high level of stimulant, issues of coffee, cola nut, energy drink. To some individuals, even a normal Coke, because it has caffeine, it can cause insomnia. Stopping those things will help those individuals to be able to regain their normal sleep. Also, the other thing is that we found out these few days, individuals that are a lot of screen time, you need to reduce your screen time, especially to prepare to relax. Going to the bedroom with your phones and certain things and do can also affect your sleep. So you need to make your room environment more comfortable for sleep, not only to reduce a lot of things that will affect your screen time, so that the individual will be able to sleep. So you can give, but you can advise on sleep hygiene. After the sleep hygiene, then you can give for a short while. If the person still complains of that insomnia, then you need to refer for the psychiatrist to be able to complete the management. Thank you.
Okay, thank you very much, Prof. Another question. What is the management approach for preparer psychosis at primary health care?
Sorry, the
Okay,
network.
let me take that again. What's the management
yes,
approach?
Take it, please.
Okay, what's the management approach for preparer psychosis in the PHCs?
Okay. That's primary health care.
Yes, sir. Yes, sir.
Okay. Well, for puerperal psychosis, there are basically about 3 different types that we have. It can be depressive, it can be schizophrenia-like, it can be mixed. So if they have depressive, then we can use antidepressant for those individuals. Like amitriptyline can be very good for them to be used. Start low, or you can use, if there are no issues of sleep, we can use a selective serotonin reuptake inhibitors, which is the SSRI, maybe fluoxetine, any one of them. Then if it's a schizophrenia-like, then we might have to use an antipsychotic in that individual. So you can use haloperidol depending on the individual or whatever. If haloperidol, if there's a lot of physical aggression, it helps to slow them down. If there's issues of sleep, that the person is not sleeping well, chlorpromazine can be used. We can use some other newer antipsychotics, also risperidone and so, depending on the type. If it's a mixed type, we might mix antipsychotic and then an antidepressant in those individuals. So in the primary healthcare, that's why we have, I trained in master trainer on a mental health gap intervention guide. There's a booklet which is given usually when you train them to have guides on which medication and the dosage they should be able to use. And what I have mentioned is clearly stated in those books. So in primary healthcare, if it is the prepared psychosis, depressive type, probably a just tricyclic can be sufficient. In some situations, it might be depressive with psychosis. You might have antipsychotic, schizophrenia like just antipsychotic. A mix, you might need to mix both of them. However, when you manage and it's not improving primary healthcare, they need to refer because there could be other background underlying causes that is causing the problem. Probably a much more serious mental illness at the background. Thank you.
All right, thank you, Prof. It is a common thing that even we health practitioners, we are not exempted, and it has to do with the case of substance abuse. And in this case, the issue of pentazocine. You know, some of us, some health workers are actually guilty of this. So somebody is asking question in line with that. He said pentazocine abuse is becoming rampage, even among health workers. How can the use of this, how can we manage patients with this addiction? Okay, for people, especially healthcare workers who are abusing this, they are addicted to it already. How can they be managed? And I will take the last question so that, Prof, you answer them together. Someone is asking here, that is Dr. Akafa. He said, why is anger not classified as mental illness? I think after this, we are going to close this session to move to the next one. Thank you.
Sorry, I can't hear the last question.
Okay, the last question is, why is anger not classified as mental illness?
Okay, thank you. All right. Let's take the pentazocine, then we'll conclude with anger. So the pentazocine, especially in healthcare personnel, managing it is very difficult. And I would say managing pentazocine dependence is best as an inpatient, not as an outpatient. Because in outpatient, you stand the risk that the individual will just come and see you and go. And you don't know what happens after he has left you. He can buy the medication, he can inject, especially health personnel. They know how to get prescriptions or know the pharmacies or somebody that they can get. So in managing it, the best is, especially for health personnel, is to be able to do an inpatient, and generally for pentazocine, to do an inpatient. However, to look at what causes dependence in the pentazocine, the issue is that we have to be cautious, especially physicians or doctors generally, in the fact that when we are prescribing, we should be cautious. There are other alternatives. There's paracetamol injection, there's diclofenac, and so, unless it is necessary before we give pentazocine, because it is the effects that they get, the euphoria they get in most individuals I've interacted with. It was when they were given the injection that they got the euphoria and then started asking, what is this injection? It not only takes the pain, it gives a feeling of high, of feeling of inflated self-esteem, which is what the desire that most individuals take it. So if we can avoid, we avoid it. If we must give, then let us not tell the patient what you have given them. Just tell them you have given an injection and so on, especially here in Africa. But of course, in abroad, my patient can request for it and no. So the first thing is to avoid using that unless it's absolutely necessary. Let's go for alternative paracetamol, diclofenac, whatever we want to use for that, for the pain. If you are given injectable, last resort should be pentazocine. Once there's a dependence, inpatient is the best care. However, failure rate is still very high because many of them become dependent on it and it's very difficult. Like we said, there's no particular drug you can give to stop the person from taking that. You can only do what we call motivational interview, motivational enhancement and treatment for the individual to be motivated to stop when he looks at the advantage and disadvantage of what the pentazocine or the substance has caused to him and what he has lost because of that. So to regain that, you need to stop this and to strike a balance. Said the second question is that the last one, which said anger is not classified. Anger is a normal emotion. It's only become classified is when it becomes repetitively and for a long time. There's what we call explosive personal disorder. When somebody gets easily angered by things that are not rational, then it can. But anger on its own is not classified as a mental disorder, because people, you get angry, but it is short-lived for a while. If it becomes prolonged, it becomes an intermittent explosive disorder where the person continue to explode and get angry over time. Then we might need to go into issues of serious anger management. But normal anger we get when something is done to you and you don't feel it right, you can get angry. But within some seconds, minutes, the person relax. Is when it becomes a repeated aspect, then it is classified as intermittent explosive disorder, where he explodes unnecessarily beyond the limit of provocation. Thank you.
Okay, thank you very much, Prof, for this wonderful and educative session with you. You know, psychiatry is a very, very special area of medicine that a lot of doctors are running away from. And I believe you heard it from him when he was giving the statistics. In the whole of Northeast, he said there are just barely 24, 25. And you know, look at Taraba, Adamawa, Bauchi. So if Meduguri has about 18, the remaining we shared among the remaining states. Now that is quite bad. So I believe some of us will pick interest to go into that field and help, you know, the teeming population that are dying from, you know, psychiatric disorders. So thank you very much, Prof, for this time. We are very grateful and we have learned, you know, that we are better than when we started this session. We are grateful. At this time, we will move into the second presentation, and the topic is management of morbidly adherent placenta, a current trend. And that will be taken by Dr. Asanarimam Elisha. He is a consultant obstetric and gynecology who has just moved into the state recently. You know, he's one of us, and we're grateful that we'll benefit from his wealth of knowledge today. So Dr. Asa, as we popularly, you can start sharing your slides and go on with the presentation. Thank you very much. I don't know if Dr. Asa is with us. If you can hear me, Dr. Bright, you can, if it is a technical issue, you can sort it out so that we move on. Okay, while we're trying to, you know, sort out that issue, the third presentation, debunking myth about dentistry. You know, we should start thinking about that so that once the presenter comes on, we'll have a lot of questions to ask. And I believe it's going to be entertaining, just like the first one.
Okay. I hope I'm audible. Hello, I hope I'm audible. Okay. I would say good morning, good afternoon, and good evening, depending on where the time zone you are in at the moment, and joining us for this brief webinar. It's an opportunity that have been graciously given to me, which I do not take for granted, to be able to just say a little word or two about this increasingly common disorder of the placenta. And unlike the previous presenter said, I think the obstetricians, we are a lot more in the Northeast, in number I mean, as compared to the psychiatrists. But that still on its own is not enough to cater for the health needs of our women and girls. So I think it's also an opportunity to advocate that a lot of our younger colleagues should also join and this noble profession of caring for women of women's health. My name is on the presentation, Elisha, and I'll just briefly be talking about the management of morbidly adherent placenta. Let me deflate your anxieties a little bit. It's not a talk that will take much time, so just give me 20 minutes of your time and we'll be done. Our slide is not moving. That's right. Okay. Just a little disclaimer. The views that I will express in this presentation are basically mine and do not represent any of the views of any association or body I'm affiliated or related with. And the clinical decisions concerning patient care and management should be based on professional judgment, current guidelines, and individual patient assessment. So by the end of this little talk, I want every member that who has been able to be with us online on this call not to be like this young man standing in front of you. I was like this when I first had my first case of a morbidly adherent placenta, and if your guess is as good as mine, you know what happened. So we're going to go through this little talk following this. We want to be able to achieve this learning objective. I'll just introduce briefly what morbidly adherent placenta is. I'll talk about the recent change in terminology, though as recent as 10 years ago, and a little of the epidemiology, and I'll dwell more on the diagnosis and management, because I feel as a vaccine obstetrician that for us as doctors, that the main thing is first to diagnose this aberrant placental implantation, and then the management subsequently will be a piece of cake. So let's go. By way of introduction, the placenta is a discoid organ which serves as an interface between the fetus and the mother, derived from the trophoblastic layer of the developing embryo, blah, blah, blah. But most importantly, is the aberrant development of this placenta that results in varying degrees of invasion of these trophoblastic tissues into the myometrium and or serosa. And this aberrant development is what is collectively called a morbidly adherent placenta. This term, morbidly adherent placenta, was first described by Irving and colleagues in 1937. Then they described this as inability of the placenta to separate from the walls of the uterus after the delivery of the baby. They had a couple of series. They had about 18 patients then, which they clinically diagnosed inability to remove the placenta after delivery, which subsequently about 8 out of them were confirmed to actually have placental trophoblastic tissues all the way into the serosa. Now, previously, these were called morbidly adherent placenta, and they were broadly described or characterized or divided into placenta accreta, increta, and pacreta. I believe most of us still remember all these terminologies very well. But however, the American College of Obstetrics and Gynecology and the Society for Maternofetal Medicine in the year 2015 adopted the new term placenta accreta sequence. Other literatures, you may find words like placenta accreta syndrome, but I'll prefer placenta accreta sequence because most of the diagnosis of this morbidly adherent placenta is made on histology. And if you take any section of the womb post hysterectomy for any of these placental, morbidly adherent placenta, you almost always find a sequence, meaning you almost always find some tissue that are just within less than 50% of the myometrium, some more than 50, and some up to the extent of the serosa. So for all intent and purpose, subsequently we'll be referring to this as the placenta accreta sequence. So this is just a schematic diagram that shows how the normal placenta is at the top right. We know that it invades, and there's a junctional zone between the placenta and the myometrium, which is formed by the Knitterbock layer, which aids in separation and shelling off of this placenta from the myometrium at delivery. So now the second one after that is the accreta, which you can see less than 50%, increta up to 50%. Then for the pacreta, we have placental invasion up to the serosa. And statistically, it shows that placenta pacreta is the most dangerous of all the forms of morbidly adherent placenta. However, like I said, it is the placenta accreta sequence. So, little epidemiology, the incidence has been rising way back from 0.8 in 1,000 deliveries in the 1980s to 3 per 1,000 in the last decade. And this is a thing of concern. Why has it been so? Of course, we know that there has been increasing cesarean section rates. Cesarean section is a lot safer. We have good antibiotics, and a lot of uterine surgeries and trauma happened from manual vacuum aspiration, from manual removal of placenta. And also, there has been increased uptake and utilization of in vitro fertilization. These all have made the data we're getting for placenta accreta sequence to be increasing generally. However, local data in our setting is very scanty. However, we have some occasional case series and case reports, but our local data has not been very, very robust. Placenta accreta sequence, 1.5% has been associated with placenta previa. Of course, we know placenta previa being either partial or total implantation of the placenta in the lower uterine segment. So what are the risk factors for PAS? Topmost is prior cesarean delivery, surgical termination of pregnancy by the use of manual vacuum aspiration or dilatation and curettage, other surgical interventions such as myomectomy and endometrial resection, and even infective processes like infections that can infective processes within the endometrial cavity that can result into endometritis. So how do we diagnose PAS? Before now, diagnosis was basically clinical and at delivery, where there is confirmed difficulty in delivering of the placenta. And this usually results in severe hemorrhage. So other clinical features that one can see could be bleeding per vaginum, especially when this morbidly adherent placenta or PAS is associated with placenta previa. Other diagnostic modalities that are available include the use of ultrasound imaging, magnetic resonance imaging, and quantification of the hemorrhage post-delivery could actually be used as an addendum to be able to guide you to recognize the fact that this is likely a morbidly adherent placenta. Now, what are the ultrasound scan findings that could help us in making a diagnosis of the placenta accrete sequence. Normal 2D grayscale imaging of using the ultrasound scan, there are certain features that have very high sensitivity and specificity for placenta accreta sequence. And one and the topmost is the loss of the clear zone within the endometrium under the placental bed, which, like I said earlier, is formed by the Nichterbach layer, which is a fibrinoid layer that is embedded between the placenta and the myometrium, which serves as a means by which the placenta can be easily shelved off the walls of the myometrium. Now, myometrial thinning less than 1 millimeter or undetectable on ultrasound scan. The presence of intraplacental lacunae, which are often large and irregular, also called as moth-eating pattern. We can also have bladder wall disruption, in which there's a disruption of that interface between the lower uterine segment and the bladder, and this could also produce a placental bulge distorting the extrauterine organs. And also, we can also find exophytic mass of placenta tissue which extend beyond the margins of the uterine wall. So, if I may ask my participants, does this placenta look normal or abnormal? While you hold your thoughts for a moment, I'll move to another image for comparison. What do we think of this placenta? Does it look normal or abnormal? I can see that a lot of people are trying to volunteer the answer, but let's just go ahead. Of course, I've made some indications that there's disruption of the bladder line interruption, and we could see some placental lacunae. This is commonly found in placenta accreta sequence. So, as good doctors that we are, learning from comparison, can we compare the first figure on the left vis-a-vis the one on the right? Of course, we can see that there's a lot of placental lacunae with the image on the left as compared to the right. And if we look at the bladder interface, here, we can see that it is already thinning and bulging into the bladder. Can we follow my cursor on the image? If you look at this loss of endometrial, of the thin lining between the endometrium and the placenta, look at it here, it's lost completely. And we can see how the placenta gradually invaded into the myometrium and projected into the bladder. However, on this side, you can see it's seemingly a normal placenta. Now, other forms of diagnostic imaging is the use of color Doppler. Advanced imaging techniques using more recent and advanced ultrasound scan machines that have Doppler features. We could use same for the diagnosis of the PAS, which include uterovesical hypervascularity between the myometrium and the posterior wall, which is just to tell us that there's already new vascularization happening between the myometrium and the endometrium. And other features include subplacental hypervascularity and the presence of bridging vessels across the myometrium and beyond the serosa. If you can follow my cursor closely, you can see that there's a bridging of vessels across. No, this is the bridging, sorry. But there's also projection of these vessels onto the bladder wall, which usually is not found in normally implanted placenta. Now, once you do color Doppler, power Doppler with a pulse repetitive flow of 1.3, and you have a velocity of more than 15 centimeters per second in the lacunae, the lakes in the lacunae. Once you have features like this, it is suggestive of a placenta accreta sequence. Now, magnetic resonance imaging, which are not readily available, and when you consider the costs vis-a-vis patient care, may not really improve or help it improves the diagnosis, but impairs speed at which we may be able to offer intervention. However, in settings that have a lot of resources, you can have magnetic resonance imaging done to be able to really tell the level of invasion, and also to help you to guide whether there's posterior extension of this placenta accretor sequence, because management may differ a bit due to the level of invasion, especially if you're considering either the conservative approach or you intend to go for a hysterectomy. So the features that we can see, normally we have abnormal uterine bulge and dark intraplacental bands and a whole lot of others, which I myself will not make such impression except with the help of a radiologist. So, but then how do we go about managing these patients? Like I said, just give me a little more time, you will soon be done. The management is multidisciplinary. Hitherto, it was just believed that the obstetrician and the probable neonatologist are just involved. Then over time, we've realized that other specialties like vascular surgeons, urologists, the anesthetists, the hematologists are all involved. And once you have a multidisciplinary team in the management of patients with suspected placenta accretor sequence, the outcome is usually a lot better than for a team of for the patient than when you have just the obstetrician taking charge of the management of the patient. So the management generally, I don't want to take you so deep, so I'll just give you the highlights or the high points of the management. For patients that you probably have had a previous cesarean section that is coming to you at the antenatal clinic, and probably you've done an ultrasound scan and you suspect that this could be a morbidly adherent placenta, delivery should be timed at within 34 to 36 weeks, because you don't want these women to go into labor because you risk hemorrhage. Like I said, 1.5% of morbidly adherent placenta, now known as the placenta accretor sequence, is associated with placenta previa. So let's always keep that in mind. So when at this gestational age, this woman should have an elective cesarean section with or without hysterectomy. Now, in carrying out this elective cesarean section, I made it bold in capital here that it's a midline incision. Why is it a midline incision? Because you want to exteriorize this uterus and be able to look at the posterior aspect of the uterus, because we can have extension to the posterior wall of the uterus, and doing just a cesarean section and thinking you can actually deliver that placenta will result in torrential hemorrhage that you may have to use the services of the vascular surgeon or other ad hoc personnel to be able to salvage or rescue this patient. So you need space. So midline skin incision and classical uterine incision. Why are we going for classical uterine incision? Because you want to be able to go above the placenta for especially patients that have coexisting placenta previa. You want to avoid the placenta and prevent hemorrhage as much as you can. So you go for a classical uterine incision. Then you secure hemorrhage and leave the placenta in situ. Then, sorry, there's a typographical error. Then you perform a hysterectomy. So let me feed your images with some of. Let me feed your eyes with some of the images you can find intraoperatively. I believe as practicing doctors, at one point in time, we might have seen something like this or similar to this at cesarean section. Well, this was taken intra-op for a placenta accreta. But however, if you look at it, there were some bulges that have been starred in the image here. There's one on image B, here, and here, and subsequently here. These were all bulges of placental trophoblastic tissue that have invaded up to the serosa. So, as a rule of thumb, for every practicing doctor, if you meet such an intraoperative finding, be careful. So this is another intraoperative finding of the placenta accreta sequence, which showed trophoblastic villi all the way to the serosa. We can see a lot of neovascularization on the lower uterine segment with a lot of new vessels, angry looking, and just begging for a little mistake or a little trauma for torrential bleeding to occur. Now I've added these two images for us to look at what I typically describe in the management of placenta accreta sequence. A midline incision, though not, a classical incision on the uterus, then subsequent hysterectomy. Then the second image on the right shows a placenta a placenta accreta sequence which had a posterior extension. We could see how vascular the posterior wall of the uterus. This is a post-hysterectomy specimen. So we could see how vascular the posterior wall is. And this is a pointer that any little trauma to this aspect of the uterus, intraoperative, can cause a lot of bleeding. Other conservative methods that have been used, even though trials have been scanty, randomized controlled trials have been scanty, in order to ascertain its effectiveness, is the use of wedge resection, especially for women that are still desirous of pregnancy, and especially for focal lesions within the myometrium. You can resect them and attempt to reapproximate the walls of the uterus. We have intrauterine balloon in the event you encounter a torrential hemorrhage, just for you to be able to serve as a temporary measure before you refer the patient for either hysterectomy or other definitive treatment. Then we can have internal iliac artery embolization, which the interventional radiologist can help us with that. Then we have the use of methotrexate. Methotrexate has been recently thrown out of favor because of the fact that these placenta post-delivery are not actively replicating, and it has been associated with subsequent hysterectomy. So at the moment, methotrexate is not favored among all the methods of treatment. However, we need more data, more randomized control trial before we'll be able to completely take off methotrexate as a method of conservative management for placenta accreta sequence. So, in conclusion, placenta accreta sequence is a significant cause of hemorrhage, and the trend has been increasing. We are seeing a lot as compared to before, and I've mentioned that cesarean section, use of in vitro fertilization, and other subtle injuries to the uterus can be one of the reasons why we're seeing higher trends of placenta accreta sequence. And we should anticipate and screen patients using our common and readily available grayscale 2D ultrasound scan. Management for PAS is multidisciplinary and involves the obstetrician, the vascular surgeon, the hematologist, the intensivist, and everybody you can call. Then prepare for massive blood transfusion, because for the patient that is diagnosed intraoperatively and attempts at manual removal or removal of the placenta, it could result into significant hemorrhage. So you always prepare for blood transfusion, and in the end, please always call for help. So thank you for your time. Thank you for listening. Where's my references? Sorry, I think my references have gone. So thank you for your time. Thank you for your attention. Please, I welcome questions and clarification. Thank you.
Okay, thank you very much, Dr. Elisha Asa, for your time and for sharing this stuff with us. You know, this stuff is fresh from the oven. You know, I earlier told you that he's one of the new consultants that joined us in the States, and we're happy to have shared in his wealth of knowledge. I believe that we all listened to him, and you know how he was presenting it so calmly, and I guess he was very audible. And O&G is an interesting field, and I know a lot of us dabble into it. And I believe with this presentation, we have several questions to ask. Therefore, I will leave the space open for those who have questions to indicate. If you have questions, you can raise your hand and I will acknowledge you and you ask your question, or comment, you make your comment. And you can also do well to drop it on the chat box where I will read it for all of us. But so far from the chat box, there are comments. An excellent and concise presentation. Well done, Chief. That is from High Chief Nkanta. Then our elder, Dr. Ebenezer, said, thanks for the refreshing presentation. Learned a lot of new stuff. Dr. Christian, thank you very much for this presentation. It is quite insightful. Then the question from the High Chief. He said, what's the management approach to a retained placenta suspected to be a morbidly adherent placenta diagnosed after vaginal delivery? So, sir, I think you can go on with that question. What is the management approach to a retained placenta suspected to be a morbidly adherent placenta diagnosed after vaginal delivery?
Okay, thank you for that question. Well, it's difficult for one to just say morbidly adherent placenta, but like I said, you risk stratify. After this prior to this vaginal delivery, if she has had an ultrasound scan, you'll be able to tell if you'll be able to suspect a morbidly adherent placenta. But if for any reason you try to deliver this placenta and you're not able to do, as doctors, our first aim is to do no harm. So I know the next thing you try to do is to do a manual removal, which good. If you try manual removal of placenta and that fails, you should just know that this is a morbidly adherent placenta. Like I said, first thing you do, you call for help. You ligate that placenta and the umbilical stump, then call for help, reevaluate with oxytocin, then go for a hysterectomy. I think that should be able to help salvage that situation or that clinical scenario. But however, trying to tug or deliver that placenta could either cause uterine inversion or torrential bleeding, which is another aspect of obstetric emergency that you don't want to handle just alone. So for all intent and purpose, once you suspect that this is a morbidly adherent placenta, ligate the loose end of the cord, call for help, and most likely go for a hysterectomy. Thank you.
All right, thank you very much for the questions and the answer. I'll have a little story to share with you all. In the year 2018, in my first session, we had a patient, that is myself and Dr. Rimande Sabo. A Chu attempted delivering his wife at home. And of course, the delivery was successful, but the placenta was adherent. And unfortunately, this man went on, to force the placenta out. And the woman bled torrentially. And at that point, they decided to bring her to the hospital. I was on duty with my friend, Dr. Sabo. Of course, management of PPH, we did everything possible. We examined, but there was nothing like a cervical tear. There was no any perineal tear. We palpated the uterus. Somehow, the uterus wasn't flabby per se. Even at that, we gave all the oxytocin. And we expected this woman to improve. The woman will improve, and after some time, the condition will deteriorate. That was how we kept on, managing. And we later referred this patient, when we discovered that the condition was getting out of hand, we referred the patient to a higher center to be taken care of. And, when our chief, Dr. Ibrahim, came, we shared the story with him. He said, when you do this and you did that, when you do all this and you discover that the woman is bleeding, he said, most likely that placenta was pulled out by force and that woman was bleeding from within the uterus. At that time, we were still, fresh doctors. And he made mention of something that we could put balloon and inflate it to provide tamponade. And thank God, that brings me to the question I want to ask now. In your presentation in the conservative management, you made mention of balloon also. But unfortunately, the question I didn't ask my chief at that time was which type of balloon, because I've actually not seen that before. I've not seen it done, and I don't know which type of balloon. And I think bringing this question here will help some of us too. Which type of balloon do we use? Is it the normal one we see? Of course, I know it's not. But what balloon specifically? And is that practice common in this age? Thank you very much.
Okay, yeah, thanks for the question. I must say that you were brave, and what you did was actually the right thing, referring at that moment. And well, I would also want to put that, yeah, the balloon that is used is not it's not, there's a special balloon. It's called Bakri balloon, and it's used for the management of postpartum hemorrhage, especially from atony. And it has been used for a very, very long time, but however, it is not readily available. So, in resource constrained setting like ours, what do? We modify and improvise like we always do. Okay, so what we improvise with, we'll get a fresh condom, and tie the end of the condom, the open end, to a urethral catheter. Then you inflate the urethra, you pass it into the womb, into the uterus, and inflate with sterile water or normal saline. Then you clip the loose end of the urethral catheter. That gives you a kind of balloon tamponade within the uterus and really helps to stop hemorrhage from postpartum hemorrhage, precisely from uterine atony. So in the event you are in a very dire condition and you need to employ the services of a balloon tamponade, that is what you can improvise with to be able to help you control hemorrhage. I just hope I've been able to throw more light or answer to your question.
Oh, yes. Thank you very much for that. At least I know I've learned something new, and I'm not the only one, a lot of us too. Well, we'll move to the next question. We'll try to round up this session in a few minutes from now. So the question by Dr. Peter Terry said, how can our colleagues in general hospital or first referral hospitals or private hospitals with limited ultrasound experience or no ultrasound at all overcome the challenge of making a diagnosis and taking precaution? And Dr. Dio Ira, his question is in line with the question just read. How can you make a diagnosis of retained placenta without a scan in the rural setting? I believe the questions are facing the same direction. So let me take the last question so that we just answer them at once and we close this session and move to the next one. The last question is this: what is the best management for retained placenta for 2 days? Probably the person that asked that question had an experience. What is the best management for retained placenta for 2 days? Thank you.
Okay, thank you for those questions. Well, you see, for most of our doctors practicing in rural settings, for me, I think the most important thing is to be able to risk stratify your patients. If you've had a patient with a previous surgery, especially previous cesarean section, and if you've had a patient that you've had a patient with multiple pregnancies, which we know that they have larger placental bed. If those patients are patients that probably had an IVF procedure done, so all these are risk factors that doctors should look out for when managing patients. So this grayscale ultrasound scan has been shown to be very, very important in diagnosis. And basically, they are not very difficult things to look out for, like I said. The loss of endomyometral cleavage plane between the placenta and the uterus is something most of us can pick if we look for them. So to be able to diagnose PAS before using grayscale ultrasound scan is not difficult, because one thing I know with the mind is what you look for, you find. So once you have a patient with a previous cesarean section and a patient most likely that has a low-lying placenta at presentation with a scan or with a placenta previa, always be keen to find out more about this placenta and be wary. It may just be a placenta accreta sequence. Then the second question is, I think the last question talked about how will you manage okay, how will you make a diagnosis of morbidly adherent placenta without scan, right? I think basically
Yes, sir.
it's a little bit difficult to do that, because it's a diagnosis that is made is a diagnosis that starts from both imaging procedures, then histology, because it's at histology that you can really tell that this trophoblastic tissue have invaded its way all through the serosa of the uterus. But it's really difficult. But however, if you see certain signs association with if you see certain signs that are suggestive or that could be that will put these women at risk of morbidly adherent placenta, it's good to be cautious about them. And like I mentioned, prior cesarean section, then low lying or placenta previa. So it's difficult to say you'll be able to diagnose that except on table, which is not the kind of situation I want any doctor to fall into, because like I said in the start of my presentation, I don't want anybody to be like the rookie I was when I first saw it. Of course, the woman bled a lot, and I wouldn't want to tell you the rest of the story, but the only good thing was that she ended up in the ICU and recovered. But it's not something we would want to diagnose either at delivery, through vaginal delivery, or at cesarean section. But however, once you have all these risk factors, in a constellation of these risk factors, it's something for you to be wary of. So for retained placenta of 2 days duration, basically what you want to do first, you want to confirm that this placenta, you want to find out if this placenta has separated, because most times we say retained placenta, but meanwhile the placenta may just be at the lower uterine segment. So you want to find out if this placenta has separated completely because it has been for over 2 days. You want to give antibiotics cover. You want to give analgesic, and first try manual removal of placenta. If that doesn't work, you can also try removing this placenta in piecemeal. However, always keep in mind there's a high risk for a hysterectomy. I don't know if I've been able to throw light on that question. Thank you.
All right. Thank you very much, sir, for the insightful session with us. We are very grateful. And from Dr. Boyce, a very erudite presentation. Thank you, Doc. He's one of our medical elders. Thank you for creating time to be with us. And also thank you to Dr. Ebenezer Paki, who has been supportive always. So at this juncture, we will bring this session to a close. Thank you, Dr. Elisha, for sharing your knowledge with us. We're grateful. So we move to the third and the last presentation of the day. That is the topic, debunking myth about dentistry. And that will be taken by one of us, Dr. Calvary Uwakata from Federal Medical Center here in Jalingo. So Dr. Uwakata, if you are here with us, you can share your slides and go on with the presentation. Thank you very much.
Good afternoon, all. I'm greeting from my time zone. I'll be discussing dental mites, the reason for most dental-related morbidity and mortality. Now, at the end of this presentation, I expect us to know what dental mite is, how dental mites make individual and community see dentistry, how dental mite makes the management of some chronic diseases difficult, and very importantly, at the end of this presentation, we should take our oral health seriously. Now, we'll be guided by this outline: introduction, definition, dental mites, ideology behind each mite, scientific principles to debunk each mite, effect of each mite on our oral health. Then we'll conclude. Historically, man has correlated disease to the wrath of God, an invasion of the human body by evil spirit. However, now there's scientific understanding about the concept of health. Might still exist for a variety of reasons: poor education, cultural belief, and social misconception. In general, mites are transferred from one generation to the other. Before the development of dentistry, mites about oral health existed and have been imprinted in the minds of people. Dental mites are deeply rooted in our communities and greatly influence the decision of where and how we seek cure for dental problems. By debunking these mites, we can help people make informed decisions about their oral health and avoid unnecessary complications. Now, dental mites are widely held false beliefs or misconceptions about oral health. There are so many dental mites, but we'll be taking just 10 of them. Now, the first we'll be discussing is, if your teeth don't hurt, there is no problem. Like the saying, if it's not broken, don't fix it. This is the basis for these widely spread dental mites. Most of our dental states are actually broken before they hurt. Conditions like dental caries, gingivitis, and even oral cancers can exist in our mouth without causing immediate discomfort. So regular dental checkups are very important even in the absence of pain. Dentists can identify dental problems before they hurt and treat them. The picture we're having on the right side of this slide shows enamel caries, which exist in almost every mouth. Enamel caries are not painful because the enamel where dental decay starts has no nerve. But as simple as enamel caries is, it has so many sequelae, ranging from dentine caries to pulpitis, and even cellulitis, the most common of which is Ludwig angina, which usually have very common complications like mediastinitis, meningitis, and even asphyxiation leading to death. Now, looking at this slide, enamel caries leading to death, as simple as it is, this is what mite could do. Now, mite 2, primary teeth are not important. Primary teeth are naturally replaceable, and because of this, parents feel that they are not important. However, they are important in development of speech, helping children pronounce sounds and form words properly. Also help them to chew effectively for proper digestion and getting the necessary nutrient for growth. Primary teeth are placeholders for permanent teeth. The roots of primary teeth provide pathway for the eruption of permanent teeth. They also support facial structures. Premature loss of primary teeth could lead to malocclusion, cysts, nerve damage, dental caries, and gingivitis. Primary teeth should be treated with same care as permanent teeth. As soon as an infant erupts the first tooth, toothbrushing should start and regular dental visits should also commence. If children develop appropriate dental habits early, they will grow up with that and take care of their teeth properly. Dental procedures are painful. Historically, before the development of dentistry and anesthetic agents, tooth extraction exists. Over 90% of people seek dental help only when they have toothache, with most requiring surgical intervention. However, with the development of anesthetic agents and science of dentistry, dental procedures are less discomforting. This might create fear and even odontophobia, resulting in late presentation. Then one other very common dental myth is brushing harder cleans teeth better. Many people assume that brushing harder will remove more plaque and give them cleaner teeth. But brushing harder damages the enamel and irritates the gum, leading to increased sensitivity and gum recession, just like the picture we could see on the right part of this slide. The goal of brushing is to brush gently and thoroughly with a soft, bristled toothbrush. Good brushing technique plus regular flossing and 6 monthly visits to the dentist is a basic dental care. So it is not about the force you apply, but the consistency and technique you use that matters most. Then one very popular myth is once a tooth is extracted, you will end up extracting other teeth. This dental myth is used to brainwash people to buy herbal concoction. People believe that it is the extraction that makes the infection jump from one tooth to the next. Tooth extraction does not lead to the extraction of other teeth. It's just that patients don't adhere to recall visits for fillings. A dentist will only remove a bad tooth when it cannot be restored, or when patient cannot afford advanced dental restorative treatments. Now, this is a common case scenario. Now, this is the first visit of this person to a dentist. The complaint is having a severe pain from the tooth labeled A. After history taking and proper examination, this treatment plan was designed for this patient. Scaling and polishing, extraction of A, GIC filling of B, and root canal therapy of C. Now, the usual response we get from the patient is, "Doctor, please just remove the tooth that is aching. I will come back for the other treatments." Patients usually don't return until C becomes painful and badly broken down like A. Then when they come, the only option left for this tooth is extraction. Now this behavior continues, and this message, the bad myth, spreads. Myth 4, oral health only affects the mouth. It is easy to assume that oral health issues are limited to the mouth. Poor oral hygiene can have far-reaching consequences. The mouth is a gateway to the rest of the body. Maintaining good oral health is essential for overall wellness. Now, how oral health affects our overall health? Under healthy conditions, the oral microbiome thrives in a favorable commensal association with its environment, just like the skin, gut, and vagina. However, under certain circumstances, certain opportunistic organisms within the oral microbiome can undergo a shift, becoming harmful pathogens. This transformation, dysbiosis, can lead to development of various oral and systemic diseases. Most oral diseases, such as dental caries and periodontitis, are both caused by this dysbiosis and contribute to this dysbiosis. starting a vicious circle. These biopsies can cause inflammation by damaging the oral mucosa, allowing bacteria and other components leak into the bloodstream, thereby eliciting a body-wide immune response. Now, these bacteria and their components, in addition to the body-wide immune response, can cause or make management of chronic diseases difficult. Some systemic diseases related to oral diagnosis, cardiovascular diseases, inflammation and bacteria from periodontal disease can contribute to heart diseases and stroke. For diabetes, people with diabetes are at high risk of developing periodontal diseases. And periodontal diseases can make it harder to control blood sugar. Bacteria from the mouth can get into the lungs, leading to potential pneumonia. Periodontitis has been linked with premature birth and low birth weight. Temporomandibular joint dislocation is caused by spiritual attack. Now, displacement of the mandibular condyle from the temporomandibular fossa is TMJ dislocation. It commonly occurs as a result of excessive mouth opening during yawning, shouting, or trauma, and sometimes even biting very large food. It can occur during sleep, usually if the person is having a nightmare and wants to scream, opens the mouth so wide and there's TMJ dislocation. Now, occurring during sleep is the main reason why people link TMJ dislocation to spiritual attack. People therefore seek spiritual solution, delaying presentation to the hospital. And some of the complications of delayed presentation to the hospital is that it makes it more difficult to reduce the dislocation. And also, muscle spasm and tissue irritation gives them pain. For long-standing cases, there could be recurrent dislocation, chronic pain and dysfunction, degenerative joint disease, fibrosis, and there are cases where a pseudo joint is formed, known as pseudo articulation. Now, this is one of the very most important dental myths. Teething is the cause of fever and diarrhea in infants. It's a highly discussed topic. Teething is the eruption of primary teeth in infants. It usually starts at about 4 months of age to about 30 months of age. Now, the common signs and symptoms of teething are excessive drooling, increased chewing, biting on anything they see, just like the baby here, swollen gum, change in appetite, fussiness, irritability, crying, and disrupted sleep. But it's important to state here that fever and diarrhea are not symptoms of teething. If a baby is experiencing any of these, it is advised that the child should be taken to see a pediatrician. The assumption that fever and diarrhea in infants are caused by teething results in delayed presentation and usually with concomitant complications. Now, this is a study done in immunization clinic in UI, where 290 women took part in this study. Now, the study looks at the prevalence of symptoms in children attributed to teething by their mothers. Over 80% of the women attribute fever to teething. 44% attribute diarrhea to teething. Now, the next study looked at the willingness of mothers to take their children to hospital when they have these symptoms and signs. Now, if we look at the red stars at diarrhea and fever, we'll see that almost 50% of the nursing mothers are not willing to take their children to the hospital when they are having fever and diarrhea during their teething age. Now this, you can see in almost street corners in the country, tooth decay and toothache are caused by worms. Now the idea that dental caries and toothache are caused by worms goes back thousands of years. And there are reasons for this. One of the reasons is that diseased tooth pulp sometimes look like worm. And sometimes dubious herbalists treating toothache give people concussion to gargle, and they spit out what looks like worm. Now these plants are being planted. The ash of the seed looks like worm. And this herbalist treating this man asked him to bend his face over burning chars of the herbane leaves, inhaling the smoke from the leaf. Now, the smoke of the leaf has nicotinic effects, which will relieve this man of the pain temporarily. Then after that, the herbalist would quench the charcoal and point to structures that look like worm on the chars. Now, the true cause of dental caries and toothache. Now, bacteria in our mouth plus simple carbohydrates plus time would generate lactic acid. So when we eat food that contains simple sugar, the normal flora in our mouth feeds on them. If given time, will produce lactic acid. Now this lactic acid erodes the enamel, leading to cavitation. Now if this cavity gets deepened up to the dentin, you start to have sensitivity. Then if it progresses up to the pulp, you have severe pains. Now this slide on the right, the lower part of the slide points at role of host. This points to the fact that dental caries is more of a behavioral disease than an infectious disease. And a lot of people say they've never visited a dentist is a sign of good oral health. Just like in general medicine, you hear people boast of good health as being defined as the number of years they've not been to the hospital. Unfortunately, there's no way you can tell if you're actually healthy without a check. This means that anyone who has never visited a dentist is likely to have calculus deposits, dental caries, or other insidious dental conditions. Please visit the dental clinic. You can see how beautiful dental clinic looks like. Now, losing teeth with age is inevitable. Fortunately, that is not true. Poor oral hygiene would lead to chronic periodontitis. Periodontitis is the most common cause of tooth loss at old age. If you start taking adequate care of your teeth early in life, you can have complete set of teeth at later years. Now we have the opportunities that were not available to our parents back then. So we should have complete teeth at our old age. I will conclude by saying understanding the truth behind these dental mites are essential in maintaining optimal oral health. Awareness programs need to be carried out to debunk these mites, as they are the leading cause of late presentation to hospital, leading to high cost of treatment and mortality. Then to my colleagues, for every patient we are managing, there may be a comorbid dental-related condition, making their healing slow or difficult. It is therefore important to incorporate dental care in the management of chronic cases. Thank you for listening. These are my references.
Okay, thank you very much, Dr. Uwakata Calvary, for discussing some of these myths exhaustively. By this presentation, we have known that some of these things we commonly hear are not true. Even as doctors, I believe some of us probably we share in some of these ideas. For instance, once a tooth is extracted, more will be extracted. You know, we've heard of this severally. And the issue of brushing the teeth harder, you know, we clean it better. I believe that some doctors also share that idea. It's possible. So this is an eye-opener to knowing the facts and the truth therein in this field. And, you know, in the course of my practice, for instance, the issue of teething causing fever and diarrhea, you know, I've had cause to explain to even a lot of enlightened people, or rather seemingly enlightened people. And some, you know, some believe me, but it took time before they believed that. So it's an eye-opener. And thank you for opening our eyes to some things, and we're better. And I believe that some of us have questions to ask. If any of us has a question, you can indicate by raising up the hand, and I'll recognize you, you know, to share the question, to ask the question. If you have a comment, you can also raise up your hand while I acknowledge you and you go on. Another option, you can drop your question and comment in the chat box. So far, I've seen some comments. Someone said, that is Dr. Richard Chibo. He said, if you can please demonstrate how best to brush the teeth. Okay, he's asking if possible, you should demonstrate the best way to brush our teeth. And a comment from the High Chief, it's a very interesting and educative presentation. Thank you, Doctor. Then he went on to say, what is the role of native snacks? That is, kola nut, bitter kola, etc., in maintaining oral hygiene. I take that again. The role of native snacks, which involves kola nut and bitter kola in maintaining oral hygiene. I think if you can attend to this before I can move further, it will be quite interesting. So you have the floor, Dr. Uwakata. You can attend those questions and we move on.
There are so many standard brushing techniques, but usually we want to advise people on the easiest one to use. Now, the easiest brushing technique that's advised is it's called the wrist roll technique, where we place the bristles of the toothbrush at an angle of 45 degrees to the gum. Not exactly 45 degrees, but you just estimate that. So you place the bristles on the gum, then you sweep from the gum to the teeth. Now, for every position you sweep 5 to 8 times. Then 1, 2, 3, 4, 5, then you move to another region. While moving, make sure you don't skip a tooth. Then you do that round the outer part of your upper jaw. Then next you go to the inner part of your jaw. So for this time now you are sweeping from the palate to the gum. The technique is named after its name because the wrist rolls while you are doing it. So you sweep 1, 2, 3, 4, 5, then you move. So when you get to the palatal part of the upper teeth, you orient the toothbrush vertically and sweep from the palate to the back of the upper teeth. Likewise, for the lower jaw, the bristles will be on the gum, then you sweep from gum to teeth. Then you go around like that. Then for the lingual part, you do same thing. The only difference is that for the anterior region of the lingual part, you orient the toothbrush also vertically and you sweep. If properly done, you see aerosols of the paste flying out of the mouth. Then you now brush the biting surface, where you place the bristles on the biting surface, and you do a gentle circle, and you move around like that. Then you end by brushing the tongue. And it is advised not to rinse out your toothpaste, rather you spit them out. Now, you should brush twice a day. And the aim of brushing is to remove food remnants. So, in the morning, you brush after breakfast. But nowadays, we don't have this regular eating habit of taking breakfast, lunch, and dinner. So, if you're not taking breakfast, you just brush, then you move to whatever you are doing. Then you end by brushing at night. Never go to bed without brushing your teeth. Then also, excuse me, you floss the teeth. The flossing helps to clean areas where the toothbrush cannot get to. So that's that for brushing technique. Then the role of excuse me, the role of kola nut in maintaining oral hygiene. Kola nut has nothing positive to do for us in terms of oral hygiene. Instead, it's negative. Now, kola nuts release pigments on the plaque on the teeth, giving it that dark, dark, dark stain. So, kola nut has nothing to play in terms of improving our oral hygiene. Instead, it makes our oral hygiene worse. Then, if you must eat kola nut, then you know that the way you should brush your teeth or care for your teeth should be intense, so that those things from kola nuts will not adhere to your teeth. And likewise bitter kola too. They play the same role. They have nothing to do for us in terms of oral hygiene. However, there's this belief, or not a belief, it's true, that usage cleans the teeth. So people that chew on one side of their jaw, the side they're not using is usually dirtier. So if they chew kola nuts on that side, it will certainly improve the hygiene better than when you don't use a part of your mouth for chewing.
Okay, thank you very much, Dr. Uwakata, for the detailed explanation. And in the course of the explanation, I believe the question raised by Dr. Peter Teru was answered. He asked of the frequency of brushing. He said there is a myth of us brushing in the morning only. But while you were explaining, I heard you mentioning us brushing in the morning and evening. And you also said after brushing, we shouldn't rinse the toothpaste out. We should rather spit it out. So thank you for that. I believe, Dr. Teru, you heard me clearly, and you are better educated now. I'm going to quickly read some comments. Thank you, sir. It's really refreshing. That is from Dr. Christian and Emmanuel Daniel. Well done, Chief. Dr. Aldo Dio, his son is a question. He said, nice presentation. Are all these teething powder and medication necessary for children? He's asking if the teething powders and medication are necessary for children. And another question, apart from toothpaste, any local alternative for maintaining mouth hygiene? Apart from toothpaste, he's asking if there are other local alternatives for maintaining mouth hygiene. Some of us that came from the village before the discovery, or rather before the movement of toothpaste to our respective villages, we have other options. So we want to know. Maybe there are more to the ones we know. So we want to know the local alternative to toothpaste in maintaining oral hygiene, and also teething powder and medication. Are they necessary for children? Thank you, sir. I believe once you attempt these questions, we'll bring the session to a close. Thank you. You have the floor, sir.
Okay, yeah, thank you very much. Teething powder is something that is very common, and the main constituent of teething powder are analgesic and antipyretic drugs or components, so to say. Now, the analgesic and the antipyretic component of teething powder usually brings down the fever. Now, they are not playing a role in teething. They're only bringing down the symptoms of most likely an underlying condition that child is having. The child may be having malaria or other childhood diseases that elevates their body temperature. Now, this child is given teething powder, the fever comes down, but the malaria is still there. And before you know, 1 day will pass, 2 days, sometimes weeks, and the baby will still have the malaria, and they will present to the emergency unit very late. So we don't advise the usage of teething powders because they only mask the fever or pain the baby is having, and it results to late presentation to the pediatrician. Then for local ways to take care of the teeth, chewing stick is a very excellent way to take care of the teeth. Sometimes, because of how chewing sticks are used, they even provide almost a comparative oral health care like toothbrush and toothpaste. Now, the reason is that chewing sticks are used for longer periods, and so it stimulates the flow of saliva for a longer period, which helps in cleaning the teeth. And sometimes some people use chewing stick habitually, so which gives them that constant increased flowing of saliva, in addition to the mechanical effects of chewing. So chewing stick is very, very good. But other local care for the mouth in terms of improving hygiene, it's only chewing stick with good advice. Thank you.
Okay, he said chewing stick. I believe I know in some communities they use ash. I don't know if I'm right. Ash, potash. Yeah. So even salt. Some people use that. So at least we're better. Chewing stick is a very good local alternative. So we are grateful, and at this juncture, I would like to invite my Oga, that is the CME committee chairman, Dr. Peter Teru, if he is here with us, to bring the vote of thanks, and thereafter I will close the meeting officially. So, my chief, Dr. Peter Teru.
Okay, thank you, Dr. Hunis, for coordinating this presentation this evening. I want to use the opportunity to thank our resource persons, the presenters, for taking up their time to educate us all. We appreciate sharing your knowledge with us and educating us. We really, really thank you for sparing the time. I want to also thank everybody who has actually found time since yesterday for this CME. When we participate actively like this with questions, it makes the presentation interesting. And we appreciate all those who have asked questions, those who just listen, for your time to actually be in the presentation. This is a continuous process, as usual. More CME presentation will come up with time, and we encourage us all to always participate and be part of this presentation, because at every presentation, there's something to learn. Like all the presentation today, I've learned a lot of things. Dr. Hunis made a comment about the myth about if you remove one teeth, tooth, the likelihood is that other ones will go. This is a common health thing that people refuse to come to hospital because of that, and we are actually properly educated for it today. So thank you, Dr. Uwakata, for addressing those myths, including those ones that affect me personally. Teething causes diarrhea and fever in children, and children come in very late with dehydration and other kind of complications. So thank you, everybody. Our ICT, Dr. Bright, you'll be very wonderful. Thank you for taking your time, and thank you for being a very reliable ICT expert for NMA. You've always been around. You've been our pillar in CME, and we appreciate the time and the effort you've actually been putting out for us. We thank the NMA SOC for giving us the opportunity to for organizing CMEs and trying to increase the knowledge and understanding of our doctors across the state to improve, our skills, our knowledge, so that we can render best care to our patients. Thank you once again, everybody, and happy Physician Week. Over to you, Unis.
Okay, thank you. Thank you very much, Dr. Teru, the CME committee chairman, for the vote of thanks. In addition to the vote of thanks, I would like to also especially appreciate some of our medical elders who have created time to be here with us. And worthy of note is Dr. Ebenezer Apaki. We also have Dr. Bawa Boyi Diama, and one of our resource person of yesterday still created time to be here with us. That is Dr. Anthony Mshelia. I can see Dr. Elachi Graham, Ibrahim Musa, and Dr. Dauda. We are very grateful for creating time to be here with us. And I also want to appreciate Dr. Chomo. I can see that he was clapping for all the presenters. He didn't make any comment, but he was clapping for them. And I believe the clap was heard properly by the presenters. And the chairman, CME committee, you forgot to acknowledge yourself too, or rather appreciate yourself. So I want to do that on behalf of the CME committee. Thank you for your effort. Thank you for choosing the presenters. And it is very obvious that this CME session starting from yesterday, all the sessions have been very, very, educating and interactive. In fact, it's one of the best CMEs we've had virtually. So we are grateful for the work you have put into that. And of course, you have already thanked Dr. Bright. So Dr. Bright, well done. We look forward to getting to benefiting more from you. And also my humble self, Dr. Isaiah Unato, thank you for being around and for anchoring the sessions. And before we leave, a little announcement. The program for the Physician Week will continue tomorrow. And by the grace of God, tomorrow there will be AGM, and that will begin by 10 a.m. And thereafter, there will be, dinner in the evening. Make sure you check the NMA page, and those in ARD state, check your WhatsApp page. Those in FMC also do well to check your ARD WhatsApp page. Announcements will be flying up and down. So make sure you keep abreast with every information that we release. So we look forward to seeing you tomorrow again for our AGM. And in the evening, we will all gather to unwind, to relax, have some nice time together. So thank you very much. May God bless you all.
Excuse me, the AGM, is it virtual or is in the NMA house?
No. It's going to be, I think it's going to be virtual. Just check the NMA page. We are going to clarify that. Check the page for further announcement. We are going to make it clear there. For now, I cannot categorically tell, but I think it's going to be virtual.
Thank you.
You're welcome. So see you tomorrow. The meeting has come to an end officially. Thank you.
Thank you too.
Chomoski.
Thank you, sir.